Peterborough City Hospital. Currently working in Peterborough City Hospital in emergency medicine. Prior to joining emergency medicine, I'm talking almost over 12 years ago. I was doing my career progression back in my home country, Bangladesh, in general surgery. And I didn't know about emergency medicine as a specialty or a standalone specialty on that time. It was many people I got involved into, especially one of my 1 year senior brother. He finished MRCSS, was working in Manchester in emergency medicine. That was when I was talking to him, I got an idea about emergency medicine as a specialty. And then I met Dr. Farook in United Hospital, where we both worked together. Dr. Farouk was preparing for emergency medicine career progression in UK while I almost was joining UK in a situation. And these kind of people, when I met them, I knew about this specialty. I went to the college website, there's a Royal College of Emergency Medicine website. It's full of resources if you want to use it properly. There was a section that mentioned about life as an emergency medicine consultant and life as an emergency medicine trainee, who was actually telling about like what is emergency medicine and what is the expectation and how your life will be as a emergency medicine doctor. So I went through that website and went through the thing. And when I finished reading the whole section of the area, I found that it was really something I would love to have because I like the adrenal surge. It is there, obviously, in emergency medicine. The same, I do not like the same patient every day going through round and round, round and round. Rather, I am somebody who would very happy to have new patients, new presentations, and unexpected presentations every day. Having said so, I chose emergency medicine and when I moved myself to UK and into the training program, and here I am.
Thank you. Excellent, Dr. Sarja. It's very inspirational. So I think people are joining in, and thanks for a brief introduction. And we are really lucky to have Dr. Sarja today with us. Again, as I said, he is emergency medicine consultant in Peterborough Hospital, and also he is an ATLS instructor and MRChem examiner. So today we have the very right topic for him. We know, Dr. Sajid, emergency in different countries. In Bangladesh, we have a different approach. We don't have pre-hospital for trauma, a lot of things. So while we're working in UK, we have a structured approach to trauma, and that's almost similar to like standardized and like ATLS protocol. I would say, would you be able to describe and first of all, I would say even before the trauma patient arrives in UK, what the emergency physician needs to do and how we get involved in trauma in emergency medicine in UK before the patient arrives?
So basically what happens in UK, as you asked very specific UK related questions, we have pre-hospital emergency medicine team and pre-hospital emergency medicine team, when they get a trauma patient in the community, what they do, they communicate with the nearby hospitals. So they have some checklist and some criteria, like a risk stratification tools we call trauma triage tool. So when the trauma triage tool is positive, they communicate with the nearby major trauma center. The hospital I'm currently working is not a major trauma center, it's a major trauma unit. So there are some mild differences between the major trauma center and the major trauma unit in terms of resources. Having said so, if they cannot reach the major trauma center within a given period of time, or if the patient's trauma triage, the risk classification is not significantly high, they communicate with either any of the major trauma units like us as a pre-hospital communication. So we call it like a pre-alert or red alerts. Different hospital has different name. And we get like an handover from the paramedics team, like what patients we are getting. So let's say like it could be a road traffic accident, it could be head-on collision, or like the car rolled, it could be even drowned. So we know that what is the history, what is the time of the event, what event actually happened, what treatment has been given, and we get a set of vitals or observations from the team. Based upon that, we prepare because we get an idea like, well, it could be a chest injury, it could be an abdominal injury, it could be a head injury who having a low GCS, it could be the airway could be a concern, it could be an like open tip feet fracture or open fracture any long bone which is having an torrential bleeding that needs to be addressed ASAP as they're coming in. So they will give you a heads up and they will tell you likely primary injuries present. And if they want something, for example, somebody is bleeding to death and they cannot control the bleeding, they might ask for an activation of major hemorrhage protocol before they have arrived. So it could be a wide spectrum of expectation from the pre-hospital team, and they may ask a specific support from you, like we're getting this patient and this is the support we need from you. What happens then on our side, it has been escalated to the emergency consultant in charge of the department of that day. And based upon the clinical scenario, they decide that do they want to run this patient as like a trauma call. In most of the cases, yes, they put a trauma call. So going to the next stage, what happens in UK hospitals when they put a trauma call, there is a set specialties that come and join the team within a given period of 2 to 5 minutes. So they are anesthetics and ITU. So you expect an anesthetic and ITU consultant and or anesthetic and ITU registrar. And then you get orthopedic registrar and SHO, you get general surgical registrar and SHO, and you have your emergency medicine team. You have allocated a specialist nurse who will be either a trauma nurse or you have a very experienced nurse with you.
Dr. Sarja, just because I know you are giving us a lot of information, I'm just going to summarize for the audience who are not familiar with this structure. So far, guys, just to be aware, it's not in Bangladesh. So in UK, we get the call from the paramedics, and the paramedics initially they have a triage tool. They follow the checklist and decide what type of hospital they're going to take the patient. So in UK, there are mainly one major trauma center or trauma unit. Okay, so if it is a major trauma center meets all the criteria and within certain distance, the ambulance are asked to bring the patient to major trauma center like Addenbrooke's or big trauma center. However, as Dr. Sarja is also working in Peterborough is a major trauma unit. So if it depends on if the criteria doesn't meet as a major trauma center or distance is not too far, those patients come to major trauma unit. That doesn't mean they cannot go to the major trauma center later on. So all the patients they miss then if they need higher specialty input and major trauma center, they always can be transferred back to the major trauma center. So this is the beauty of trauma management in other countries other than Bangladesh. So they have a pre-hospital system where in the community paramedics go assess the patient, make a decision, and already start the communication between which hospital to take. Also, as he said, they already we call pre-alert. Okay, in the department we have a red phone only for ambulances. So when the red phone rings, we know there's something emergency coming in. So of course, this pre-alert will tell briefly what is coming in. Let's say usually we get at least 5, 10, 15 minutes window before the coming. So based on that pre-alert and based on the what type of patient is coming in from the community, then we activate our local trauma call. Okay. We have a local trauma team who comes on every major trauma call. So based on that, we activate a local team, and then I would say, and then Dr. Shaza will tell us what is the trauma team looks like and how do we approach when the patient arrives. Anyone have any question in between? Just raise your hand. We can or type in the text so we can address your questions as we go. Okay, Dr. Shaza. So thank you again. So let's say the patients just being almost being arriving, but you activated the trauma call in the trust. And who are the people we're expecting and how do you prepare, please?
Sure. So as you mentioned, like when you put the trauma call, a set of specialties people arrive. We mentioned before, it is from anesthetics and ITU team, orthopedic team, general surgical team, and the emergency medicine team, because you have made the call. And the trauma call will be run, and expected it will be run and led by emergency medicine doctors with the help of other specialties present there. So when they arrive, we have in different trusts and different hospitals and different areas of UK have different way of managing it. Generally speaking, going back to the principle, there we call it there's a briefing happens. So briefing happens by the team leader, trauma team leader, usually in this case, an emergency medicine registrar or emergency medicine consultant. They give the team And first, it is a simple introduction, like who is from which team and what training level or training standard they have. Generally asking that, are you ATLS provider or are you ATLS certified or not? Because if you find in your team member somebody is not ATLS certified, you understand that the skill of managing trauma is not up to the mark. So you can still use them in your team, but you might not give them a critical job in trauma call. So what happens here? You brief, this is our patient, this is the observation of the patient, and this so far the information goes. These are suspected injuries we are suspecting from this trauma, and you discuss with the people, and you role allocate and give specific. For example, straightforward for the anesthetics and ITU team, you can say the anesthetic, like if the patient needs an air, would you mind go to the head and assess the airway when I ask you to? Then you have an ITU doctor, ITU SHO registrar. You might ask, would you mind put two whiteboard IV cameras and take trauma bloods? And also you can do the gas and let me know when it is done. If you fail for 2 attempts, just let me know. I will escalate it to somebody else. It needs to be, we call it closed loop communication. Then you have your surgical and an orthopedic doctor. You can ask either your surgical and an orthopedic doctor or your junior SHO of the emergency medicine or the registrar of the emergency medicine to carry on the primary survey, which is the primary or the most important thing as the patient arrives. We disclose in you to run gases, and if I need to have a specialist nurse, they will keep the time and they will describe whatever happening because it's a big show going on. You cannot document everything with a time to stamp. Yeah, there will be a dedicated nurse who can go through the things like, okay, they are documenting as things are happening automatically. You also have a specialist nurse dedicated for this trauma call. You can ask them to put the patient on observation, and if you require an ECG or any other pain control medication, to let them know. And when it is done, like this briefing and job allocation is done, you ask them, do you have any questions, or are every one of you happy to carry on this job role? And later on, what happens in real life scenarios, they all disperse, they all start doing or preparing for the stuffs that they need to do. They check, like, if my observation machine is working, the anesthetics check, like, do I have adequate machine, adequate instruments, and everything is ready or not. So this is how we start. Dr. Farouk, do you want me to carry on in the primary survey, or is there any question or
Yeah.
anything?
So just to summarize for the audience, also just to simplify, so Dr. Sarja has briefly described initially what happens in the community, how we get the red phone or pre-alert before the patient arrives. Also, part of that preparation, we put the local trauma call. The trauma team arrives in the resuscitation area. This is very important. So we have a specific area called resuscitation for acutely unwell patients, and those areas have a couple of beds, and we have one specific bay only for the trauma patient. So obviously, we said when the team arrives, the teams generally comprise of any registrar or consultant as a team leader. We have general surgery, SHO or registrar, or both orthopedics. We have I2 anesthesia minimum. There is a sometimes there is a trigger response team. Depends on pediatric or adult. There may be other specialty coming in. So once they arrived, as Dr. Sarja rightly mentioned, that we debrief the team. Okay, we tell them what's coming and what needs to be done, and we allocate roles. Okay, for example, if IT anesthesia, we ask them to manage the airway. Okay, if unless we have someone else specific, or sometimes even ED can do it, but depends on the manpower. Also, someone who is ATLS trained, we can ask them to do the primary survey. Okay, and also there are nurses for monitoring IV access. Also, there are other things. I think we allocate someone to scribe, to document. We have a red booklet called trauma booklet. So someone to scribe, because documentation and timing is very important for trauma. And the other things I'm thinking, Dr. Shaza, I think we sometimes we also allocate someone to book a trauma scan or imaging, and make sure this is vetted. So someone to book on a trauma scan, it's a CT scan, because you need to book it online, and maybe sometimes you call the radiologist and make them that they're ready to go. Also depends on what type of patient. If it is a major hemorrhage, we activate the major hemorrhage protocol. Of course, if it is a obstetric neonatal, so we involve the relevant team at the same time. So these are all preparation. This is the beauty of emergency medicine in UK or other countries, where even before the trauma arrives, we know what's coming. We have the people and resources and the space ready, equipment and the life-saving medication or treatment bloods ready. Guys, whoever working in Bangladesh, just bear in mind these are the changes that needs to happen at some point. So one is pre-alert, we have the preparation, and now we'll definitely will go for the actual when the let's assume the patient just arrived in ED with the crew, and Dr. Shaja will tell us what we do when just arrived in the emergency department. Thank you.
Thank you very much, Dr. Farook. Before going to that, just to add on the space, Dr. Farook, that what we're talking about is nothing out of ATLS. This is the standard of practice in majority part of the world. So you talk about the Western countries, you talk about the Middle Eastern countries, everybody follows ATLS. ATLS is established by American College of Surgeons. This is a well accepted course in the wider version of the world, and we call it a singular language of communicating where there's a trauma management. So what we are telling here is the basic ATLS protocol, and the expectation is majority of the countries, you go to Singapore, you go to Middle East, you expect the same and the similar way they're managing the trauma. There's nothing more, there's nothing less. But that is what the standard that we are expecting.
Yeah, thank you.
Fine.
So I think
So
so. What I'm trying to say, Dr. Shaja is saying, ATLS is a common language. Okay, that managing trauma is nothing should not be different in different countries. Okay, it should be the same language across the world, Bangladesh, America, everywhere, whether we practice or not. So it is our job to actually learn the ATLS protocols and apply, even though if it's a remote in village in Bangladesh. But once you have the knowledge, you can apply as you go. Okay, so go for it. Thank you.
okay, so carrying on to the next stage, as the patient arrived, we have our trauma team here. We know our expectation of the patient or the suspected injuries. We have job allocation, and our team is ready to crack on. As the patient arrives, there is a handover happens from the pre-hospital team, which could be a paramedics, which could be anesthetics, or even emergency doctors who work in the pre-hospital realm. So there is a team leader from the pre-hospital team who will give you the handover, and there's a team leader in our trauma team, which is us, the emergency medicine registrar or the doctor. They will take the handover. So two team comes together. The patient is on the ambulance trolley, and the handover happens from the ambulance team to the emergency medicine consultant or the emergency medicine registrar, who's the trauma team lead. In this situation, there is the first thing is like, are you going to move the patient immediately to the hospital trolley, or the patient stays in the ambulance trolley is probably the first question. So it varies from person to person. Some people take the patient to the ambulance trolley, get the handover. Some people say, no, you can be still on the ambulance trolley. I'll get the whole handover, and then we will take over from you. So generally speaking, and that happens in a structured formula, like they have a structure, they can go see like when the events happen, what was the event, what was the treatment given, what time was the treatment given, if there is any specific medication like ketamine, morphine, and other medication being used pre-hospitally, they mention these amount of ketamine, morphine, or Entonox we have used, and what time was given, or we have given some paracetamol or TXA. In UK, the pre-hospital team can give some medication, especially if when the pre-hospital emergency medicine doctors got involved, they have the right and the skills to give some medication in the pre-hospital. If they have given those things, they will give you the handover, because what you do not want, you don't want to overdose the patient with these critical medications. So you get the handover from them of all the events. And if you have a question like, is the patient allergic to anything, any past medical history, when the patient last ate or drank, or any other, we call it ample history, what I'm actually mentioning. You ask when you are happy with the handover, you say, fine, now we take over. The patient comes to your trolley, and basically at this time, the most important job is the trauma team lead and the primary survey people, because everybody is jumping on. Because you have allocated someone to do IV access, they are jumping on the hand doing the IV access. The anesthetics is checking the airway if there's any acute airway concern. So you as a team leader has to communicate with everyone that is everyone is happy. What primary survey happens? This is the A, B, C, D, E, the basic way of communicating in emergency medicine or any acute management setup. It's airway, breathing, circulation, exposure, and D and the exposure. So the primary survey doctor, who is an ATLS trained provider, will go through like if there's an airway concern, if there's a breathing concern, if there's any C concern, D concern, E concern. I'm not going into in depth of it because it literally tells like that you have to do an A assessment, look, listen, feel. You have to do B assessment where you listen to the all four areas of the chest, you percuss, you do the expandability, you check the saturation, the respiratory rate, and you find out if there's any life-threatening injuries. C, you do the same thing. You check the pulse, if check peripheral pulse are present or not. If there's a blood pressure, you ensure there's two whiteboard IV access. You ensure bloods, group, and safe. And gas, when I say gas, I'm talking venous blood gas at least, has been sent. If the patient is connected to the monitor with like 3-lead ECG, regular blood pressure monitoring, saturation, pulse rate, and then you carry on with the checking the GCS, BM, and any other injuries anywhere. Now, going back to the yeah.
Dr. Shaza, just I'm sorry to just to have a pause. I know we are going very fast for many, so because of the time frame, of course, I would like to say, if anyone has any question, raise your hand, and you can ask. We can slow down. The other thing I would like to briefly say, the Dr. Shaja briefly mentioned about the handover thing. Okay, so paramedics brings the patient to ED. ED team is ready. The trauma team is ready, and then the question is, the handover is the paramedics will tell you briefly about what they did with the patient. So whether the handover, so what happens is we need to transfer the patient from the paramedics trolley to our trolley, to ED trolley. So that was a physical handover with lots of monitoring cables and everything. Okay, so that transfer sometimes takes few minutes or a bit longer because it's a complex process and there is a bit of chaos. So if sometimes, if the patient is stable and not critically unwell, we take the handover before the shift. Okay, so it's easy. So that everybody's quiet, everybody's listening, and once the handover happens, then there's a bit of chaos. You have to stop everyone and take the handover. That is with you. So while we are taking the handover, obviously someone is scribing, someone is writing. There is someone allocated to document. We have a trauma booklet. So we have a trauma booklet. Second, sorry. So we have a trauma booklet that we allocate someone to write. So once the agreement is done and handover is done, okay, then we transfer the patient to a trolley, okay, where, as we said, people are already allocated. The anesthetist in the head end, usually they also manage the C-spine, okay. So airway and C-spine managed by the same person, ideally anesthetist or anyone who is in the head end. And then, as Dr. Shaza said, anyone ATLS provider had some ATLS, we allocate them for ABCDE assessment. And that was a brief. We're not going to go details in the ABCD. We don't have the time, but I think that's where we are at. Anyone have any question at the moment before we jump into the next session? You can unmute and start talking. If not, Dr. Saja, if you continue, please.
Okay, just thank you very much, Farouk. Going back to the previous situation, obviously, I know that all of us here is Bangladeshi. So the CS spine management, what happens in UK, it's almost every time the patient is CS spine immobilized in pre-hospital. So that's why in my talk I did not mention that thing. So in your setup, you might not get the patient CS spine immobilized, or you will not get the patient CS spine immobilized. So you have to do a quick CS spine assessment and decide, are you going to immobilize the CS spine? ATLS still mentions about 3-point immobilization, which is a collar and some blocks on the side. But in practice, we have come to a decision like we mostly go with the blocks. If required, we go with the collar. But ATLS is mentioning about 3-point immobilization to ensure that CS spine is immobilized properly as your primary survey going on. And the other thing that I would like to add on in the primary survey, what is the principle of primary survey? Why we are doing a primary survey? Why this thing is there? This is to identify life-threatening or limb-threatening. So when I say life-threatening injuries, during the primary survey, you might found the patient is having a pneumothorax. You will still carry on. You will tell your team member or the team leader, like, there is reduced air entry on the right side. I'm suspecting it's a pneumothorax. You carry on. You don't do any necessary actions. However, if you see the patient is having a tension pneumothorax, you stop there. I'm suspecting a tension pneumothorax. The patient saturation is on the lower side in 50-liter oxygen. There's no air entry on the right side. The trachea is on the other side. AKA, you get all the clinical findings of a tension pneumothorax. The patient is unwell, the patient is paralyzed, and you found life-threatening injuries and the time critical injuries. If you don't take right actions in a due course, the patient will have harm, which can be even losing their life. So you take necessary actions. Now at LSA, you can needle decompress in your area of safety, or you can go finger thoracostomy or putting a chest drain tube. Obviously, putting a chest drain tube will take some more time. Your primary action here is to take the tension out. So in many cases, you can do a finger thoracostomy or you can put a needle thoracotomy, and as the tension is out, you carry on the primary survey. So long story short, the purpose of primary survey is there's any acute life-threatening injuries. If I don't take necessary action now, the patient will die. You might say there's a fracture. The patient is not dying for a fracture now. That might be a destructing injury. So that is how the primary survey goes on. The person who is doing a primary survey, their only goal is to identify any time critical injuries that needs actions now. If there's nothing, which happens in many of the cases, then you say, I've finished my primary survey. And as the primary survey doctor, they hand over to the team leader in a way, I'm happy with the airway, or the airway is not good. The anesthetics is not putting like an OPA or an IGL or something. This is my B assessment, this is my C assessment, this is my D assessment, this is my E assessment. And the primary survey doctor then asks the team leader, the emergency medicine consultant or the registrar, is there any information you need from me? Because in the height of excitement, you might have missed some of the vital signs, like, oh, you haven't checked that findings, or did you check the people, or you probably forget to check the people. Is the patient having a lateralizing sign or anything? So it's a teamwork. It's not about being judgmental, because we all know in the height of these acute moments we will miss stuff, and that is, we're human, and that will happen. The team leader's role is here to ensure everything happens in an ideal way,
Yeah.
and the team leader will yeah.
No, so thank you, Dr. Sarja. I think is a very important key focus that Dr. Sarja is trying to remind us is what is killing the patient. Okay, are we addressing that rather than moving like find all the injuries at the same time? So I would say life-threatening emergencies gets the priority in any trauma survey. Okay, it's airway, C-spine, even catastrophic bleeding. Okay, sometimes if you're bleeding, you just don't watch and bleed and die someone. Even though it's not a formal protocol, but you have a tourniquet, have some gauze and some pressure, stop the bleeding, those things. Airways of concern, get the anesthetist or someone sort the airway. Breathing, if it's tension pneumothorax, you focus on that, needle decompression and chest drain or finger thoracostomy. So all these things needs to be done almost simultaneously as you go through A, B, C, D, E, or you allocate someone specifically for that, chest drain or needle decompression, and you can carry on for the rest as someone is focusing on that life-threatening injury.
It looks it looks into the bone injuries, it looks into the vascular injuries, and or any other injuries, like you're having a bleeding inside the body. It looks into the lungs, find out if there's any hemothorax, pneumothorax, or any other actions needed to be done. And it obviously looks into your CT head and your CS spine. The patient should be on the, if you decide the patient needs a trauma scan, the patient needs to be on a trauma board and make immobilization till you have a CT trauma scan done. When the CT trauma scan is done, then you, as the emergency medicine leader, will look into the trauma scan, see if you can see any acute obvious injuries. And usually in UK, the expectation is within an hour of the CT scan done, a radiology consultant or a specialty registrar will report the CT trauma scan within an hour. Now, different hospitals have different practices. Some hospital, we call it hot report, which is quite popular in trauma setups, especially in the major trauma centers, that a specialist radiology doctor who is specialized or dedicated for the trauma setup. They will do a hot report. They will go A, B, C, D, E, airway, no acute concern. C spine, I cannot see any major breakdown. B, I cannot see any obvious pneumothorax. There might be some refractures. I'm not worried. There is no flare segment. So they will give you a hot report. AK, they are going to tell you in the CT scan, we cannot see any acute, time critical, life threatening injuries. And then within an hour, you get like a full CT scan report, which is like a quite big 1 or 2 page report of every single thing. What are the injuries? What are the incidental findings? And based upon that, you take your necessary actions. While the patient have the CT scan done, came back to your department, and you're waiting for the CT scan to be reported, then we go to the next stage of the trauma that is called the secondary survey. Now, what happens in secondary survey? Yes, perfect.
Raza, I'm just going to have a pause and again to reflect what you said. Absolutely, people all Bangladesh, you're listening. So it's very important that we shifted from having X-rays to trauma CT. So these days we're suspecting traumas. Usually, therefore, I mean, suspecting traumas, or we say suspecting some maybe chest, some abdomen, neck. So we go for it, something called CT trauma scan that includes head, neck, chest, abdomen, and pelvis with contrast. So this is very important. That patient, as we know, that patient needs to be on a trauma board. Okay, the trauma board is like a it's a rigid board, but it's a soft foam on the top, and that patient needs to lie still with the neck immobilized as well. It's uncomfortable for many. Also, it depends on the patient. If the patient is GCS head injury, GCS 3, or very agitated, vomiting, we may decide to intubate the patient before we move to the trauma scan. So make sure all these acute issues are addressed. Intubation, whether it's chest drain, everything needs to be sorted before we move that patient to the trauma scan. And obviously, as we said, usually it depends on where you're working. Sometimes even the patient, before the patient arrives, we call the radiologist, make them aware that we have a trauma patient coming. We might need a potential trauma scan, because radiologists need to vet the scan. So they need to say, we agree to scan the patient. So that's a pre-alert, and make the radiologist ready. That happens. So we make we can allocate someone to do the scan and vet the patient and vet the scan. And when the patient is ready to go, that means patient, all the life-threatening injuries are addressed, airway, breathing, everything. And even if it is a major hemorrhage, we may start even blood transfusion. So all these things needs to be ongoing, and patient is relatively stable to move to scan. If, let's say, a very unstable patient, exsanguinating bleeding in the abdomen, Dr. Sarja might say more detail, that patient even might just directly go to the theater, okay, bypassing the scan. All these things needs to be addressed. So that's also a decision whether the patient is suitable enough for a CT or unstable enough to go to the theater directly in collaboration with surgical and neurosurgery orthopedics team. Also, as you said, trauma scan does not involve the limbs, the arms, legs, open fractures. Sometimes we ask people to do X-rays on the limbs, and that X-rays can happen later or at the same time after the trauma scan. The patient go to the X-ray and come back. Depends on how the patient is doing. This is all happening. So as I'm saying, everyone in Bangladesh, I think there are very few places they have a trauma board. Okay, in Bangladesh, very few places I've seen they use the C-spine, collar and blocks, or even tourniquet. Properly, people can use the tourniquet. Bedside ultrasound sometimes if it is a unstable patient and a massive bleeding in the intraperitoneal. Or in the abdomen, we do the fast scan. Depends, okay. Depends on the stability of the patient. If they need to go to the theater bypassing the CT, they can have a fast scan in ED. I'm sure Dr. Sarja will give some ideas about this, and then we'll carry on the secondary survey.
Sure. Thank you very much, Dr. Farook. So yes, as we were mentioning, that as we did a few other augmentations, things that we can do while the patient is either gone for CT scan or come back. Fast scan, it is a decision of the team leader that do you need to do a fast scan? It's not a regular practice like we do it for every patient, but there are patients that needs to have a fast scan. For example, if the patient, we haven't found any obvious acute life-threatening injuries, the patient is unwell, the patient is having any just unstable, and we need to find out like, well, does the patient needs to go to theater or somewhere else? In that case, you can do an extended fast scan, which looks into the abdomen and the chest, and could be an echocardiogram to find out if there's any acute bleeding happening in some areas that needs actions to be taken. So fast scan has role in this situation, but it is very much dependent upon who is the team leader and what is the situation and what value eFast is going to add on. So we do it? Yes, we do it. Do we do it for all patients? No, we don't do it for all patients. And any other actions to be done, like a chest and tube, or Dr. Farook already mentioned, like intubation if it's required, CSPN immobilization. So we try to ensure the patient is not deteriorating. We try to ensure that everything has been looked into. And in case of unstable patient, they might bypass CT scan. They may go to theater for like an emergency laparotomy. Just sometimes it's like a packing laparotomy. Even they couldn't find where the bleeding in. Other thing that I did not mention during the primary survey is pelvic binder. If you suspect the patient is having a pelvic injury, you can put a pelvic binder on. So now I understand, like if you go to the books, read about it, there are multiple pelvic injuries that can have a pelvic binder. Some pelvic injuries, you don't have a pelvic binder. But in primary survey time, you don't have that much information to work on, like what kind of injury it is, should I put a pelvic binder? If you suspect a patient is having a pelvic injury and the patient is unstable, you should put the patient on pelvic binder unless otherwise proved. And when you have your CT scan done, you find, okay, the CT scan will tell you what injuries you got in the pelvis. And based upon that, then you decide, am I going to carry on the pelvic binder or should I leave the pelvic binder? And rule of thumb is when you remove the pelvic binder, you have to re-examine the patient A2 assessment very quickly, and you have to ensure a re-pelvic X-ray done, because if it's an open book fracture, you have done a CT scan that shows, oh, everybody's in place, because it's just an open book fracture. Everything is in place. You move the pelvic binder and the pelvic got open because it was an open book fracture. Then you must re-X-ray. It's a medical and a legal responsibility of the healthcare professional to re-X-ray the patient after the pelvic binder is removed to ensure there is no injury like an open book fracture, which was basically closed by the pelvic binder, and take necessary actions. So, and then you carry on doing the secondary survey. Now, we mentioned the primary or the principle of the primary survey, the purpose of the primary survey to identify acute life-threatening, limb-threatening, time-critical injuries. What is the secondary survey? Secondary survey is to find out what are the other injuries that needs to be addressed, but they are not time-critical, life-threatening, or limb-threatening. So that includes, that could be any fracture in the upper limb, like a humerus fracture, like a Colles fracture, finger fracture, or any wrist bone or the hand fracture. That could be that could be even a femoral fracture or a tib fracture or any other fractures anywhere else. And find out if there's any other injuries anywhere else, like there might be a laceration in the anterior torso or the posterior of the patient. So that requires a full top to toe detailed examination of finding if there's any soft tissue injury, if there's any likely bony injury, if there's any laceration, and you have to body mapping. When I say body mapping, Dr. Farook mentioned in this part of the UK, we call East of England, we use a trauma booklet. So similar booklet has been used in different parts of the United Kingdom and other part of the world, where you can see in the booklet that it's like a photo or diagram of patients front and back. What you do in the secondary survey, you found, for example, you found there is a bruise in the wrist. You're suspecting there could be a scaphoid or a radius fracture. You don't know because you haven't done an X-ray yet. In the booklet, you will mark that area and you say like there's bruise and a suspected injury, because you don't need to write a whole 5-page of thing. It's just like body mapping. You go and you just mark it and write 2 lines over there so that whoever is opening, because it's a time critical situation, the trauma, whoever is opening the booklet gets an idea very quickly. Now, based upon your secondary survey, you then request further scans, which could be mostly x-rays of the injured area, and you take necessary action. There could be some other things, like if you see like there's an area of wound, which is a laceration, which is quite dirty, you might need to give tetanus prophylaxis to this patient. You might need to give some antibiotic cover because there's a potential of infection on that area. If the area that needs wound cleaning and that needs laceration closure, you have to take necessary actions. So generally speaking, in secondary survey, you do a body mapping top to toe. You find out if there's any other injuries that was not addressed at the time of primary survey, because that was not the purpose of primary survey. You find out the injuries and take necessary actions. Now you get a fracture, you take the right management of the fracture required for the patient. And then the patient goes to the next stage uh, of the treatment. Either they get admitted or they get discharged. They brings back to. So many times trauma patients, they usually get admitted for multiple reasons. And then a question comes, which Dr. Farook will put some light on, like, are you going to keep the patient on your hospital, on your research, or that goes to the trauma unit or the like a major trauma center?
Yeah, and that's a very important question. I think I was about to ask you the same thing. The thing is, let's say you are working in a trauma unit. That means you don't have all the specialties in your hospital, because in trauma, to managing trauma, you need neurosurgeons, surgeons, orthopedics, maybe vascular surgeon. There are so many other different specialists. So if you're working in a hospital, don't have the specialist input in the same trust, you can actually talk to the major trauma center to address everything in one go. Many times it happens that, oh, our hospital don't have neurosurgery. Most of the hospitals don't have neurosurgery as a trauma unit. If it is we suspecting spine injuries, or like multiple organ damage, so multiple organ injuries, and there needs multiple specialty input, very unstable patients, those are the patients meets the criteria. There is a checklist as well. They meet the criteria to transfer to the major trauma center. That's again through the hospital, and again there is the ambulance. We blue light the ambulance to the major trauma center after the agreement is happened. But that's also a bit of process where you have to do the call the trauma network, the number for the trauma network. There's someone in the other end have to listen to the story, and then agreed, and also they might ask for further scans or further input before you transfer the patient, and make sure the patient is stable enough to go there. That may take half an hour, 40 minutes journey somewhere. So I think we briefly covered a couple of things. One thing's what happens in the community. So when a trauma, I'm just summarizing for all of us here. So Dr. Sarja, again, I'm trying to whoever joining later. Dr. Sarja is an ATL instructor. He's a consultant in emergency medicine, and also has a surgical background. He's a consultant in emergency medicine in Peterborough Hospital. He's an ATL instructor and MRChem examiner. So if you have any question, this is the right time to ask. I'm telling you. And the other thing, so far we discussed few bits of things on approach to trauma patient. It's in UK, but I would say it should be ideal everywhere in the world. So that's why, as I'm saying, we don't have in Bangladesh, we don't have pre-hospitals. So we discussed about what happened in the community when the trauma happens, and what the paramedics. So when the paramedics go, they do the same thing. They do the primary survey. They try to stabilize the patient. So everything we do in emergency department, the paramedics try to do the same thing, but not at the big extent. They would like to even if the patient is, sometimes even paramedics can intubate if they have a support. Okay, so in the community in UK or other developed countries, paramedics sometimes helicopter emergency medicine, we have critical care, and an A&E doctor accompany the paramedic. They can actually go in a actually critical trauma patient. They can intubate in the community, put a chest drain, put a vascular access, even arterial line. So sometimes we receive a patient fully intubated, art line. The splint is on the limbs. There's an open fracture. There is a tourniquet. So all these things ideally can be managed in the community, and actually in UK most of them are managed in that way. Okay, so imagine this is why I think is our in Bangladesh, I feel we do need a pre-hospital team actually to make those patients up to our, come up to be stable enough to come to the hospital. To be honest with you, many patients, we said there's a gunshot violence in Bangladesh. By the time they arrived, doctor called dead. The reason is because there is no pre-hospital. To be honest with you, the pre-hospital does the same thing in a more concise way, just address the life-threatening issues and then bring to us as soon as they can. They're not there to do the secondary survey. They're not to do any detailed survey at all. Okay. So that's one thing. So we discussed briefly the pre-hospital. When they decide which hospital to go, they come to the pre-alert, the local hospital. We get the red call. We activate our trauma team, and we have team members we allocate, and then we receive the patient as soon as they arrive. Usually it's 10-15 minutes window. And then, as Dr. Sarja said, once you allocate, everybody knows their role. But as a team leader, we need to make sure that this is verbally, there's a closed loop communication. Someone is documenting, someone is calling to the radiologist. Okay. So as a team leader, you just coordinate like an orchestra. That's what, as an emergency consultant or physician registrar, we do here. So everything is done in a concise fashion, we address all the life-threatening injuries, and patient is stable enough, go to the CT scan. Yes, we move the patient to the CT scan as soon as possible. Ideally, in major trauma center, they say target time is 15 minutes, but it doesn't happen all the time. But 15 minutes is the time we expect to do the primary survey, addressing the life-threatening injuries, and try to move the patient to CT scan within 15 minutes. Depends on the situation. And then after the CT scan, yes, we can add on some X-rays if the patient is still stable. Also said, there are cases where the patient directly can go to the theater. Also, once in a local hospital, if you're not a major trauma center, this patient, if you think there's multiple injuries and we need some other specialty input, they can go to the major trauma center. And also Dr. Sarja briefly mentioned about secondary survey. That's after you address all the primary surveys. Secondary surveys, mainly minor other injuries, not life-threatening injuries. There are open fractures, there are like facial injuries and other injuries. Okay. So all the injuries can be, so we have to again detail examine the whole body from head to toe, and we can allocate someone to do that and document. We have a trauma booklet. We have to, there's a photos we can identify, we in the map, and of course we document everything, and then depends on what is the major injury, we admit the patient or send to the theater under one specialty with input from the other specialties. um, Dr. Sarja, I think we summarize. Anyone has any question at the moment? I know we are going very fast, and many of us probably haven't had a ATLS course in Bangladesh, so it might be a very bit of a lot of new terminology, a lot of new information. However, we have, let me see the time. So we are nearly 1 hour target. Okay, another 7 minutes. Anyone has any questions?
Hello, sir.
Yes, Dr. Samira, please.
Sir, I wanted to know how do we manage the ethical issues in this acute situation? Like someone might have religious issues regarding blood transfusion, or someone might have signed DNA or form. So what do we do in that situation?
Right. So you're asking if someone has a religious issue to not to have blood transfusion, and someone might not agree with DNAR.
Yes, sir.
Okay. Dr. Sarjak, would you like to highlight something?
Sure. Thank you very much, Dr. Samir, for the question. It's a very complex and interesting question. It tells like that you have a lot of insight regarding this. So basically, managing ethical thing, you have to go with the basic ethical management. So your first question was if the patient has a religious value and the patient does not want a blood transfusion. Now, I understand from your question, you're probably talking about a Jehovah's Witness. These are the people in most of the Western countries, a fraction of Christianity who believes that blood is sacred and you cannot have blood transfusion or blood product transfusion from other people to your body. And they are quite serious and quite dedicated in these matters. So if the patient in front of you have capacity, they have GCS 15, you can ask like, okay, obviously you are not going to give blood to them without communicating with them. The the portion that we did not mention, if the patient has GCS 15, you have to continuously update the patient. Like, okay, we have done this survey. Now we are moving you to a CT scan, or we are going to give you some blood. Do you have any question, or do you have any preference? If they mention that I'm a Jehovah's Witness or whatever I am, I have a preference, or because of my religious value, I don't want to take blood, you have to address patient's concern. Even the patient has a terminal or a critical outcome or die because of that reason, you have to follow whatever the patient is saying. You cannot say like, no, this is not a right decision. No, this will be patient. So if the patient has capacity, you have to act accordingly. Now, you may get a patient who is like GCS 3 or GCS 4, hardly communicating, just responding to the pain. You don't have any family member, and in your hospital system, you do not have any information provided. And you have given the patient blood and later found out this patient used to be a Jehovah's Witness who would not like to have blood, then you have to be honest. Like, look, it was an acute life-saving measure. I did not have any information, or you did not carry any passport in your body that I know that you have a value. I have given it. And I'm sorry for that, but it has already been given. And then you have some religious leaders on the Jehovah's Witness. Every hospital or every community has similar religious people. You can involve them. Like, look, I got a patient. I did not know they are from the same community. We have given the patient blood. It was a life-threatening measure. Can you come and support us? So there are support system. Now, you are okay in this field because you did not know, and this was the right action to be done medically to save the life, and you did not have any clue what is the religious value of this patient. So that is how two things. One is you communicate with the patient, ask, or if there's any patient relatives or next of kin we mentioned in UK is present, you ask them, do they have any value or any expectation in this situation, what to do? Your second question you mentioned, forgotten. What was the second question? Sorry.
Sir, if they have signed any DNAR form, that is.
Okay, so talking about the DNR, so the DNR usually may come with the patient. Unlikely in trauma setup, the patient gets a DNAR. So generally what Dr. Samir is asking, in UK, we have like a passport, we call it DNAR. Now we call respect form, where we mention what is the escalation plan of the patient. We mention the patient is not for CPR or do not attempt CPR. That is called DNAR or DNA CPR. So if you have a DNA CPR, you still will do your normal trauma management, because DNA CPR does not stop you to put a chest drain tube to a patient. DNAR does not stop you to give blood transfusion to a patient. DNAR does not stop you even to intubate a patient if required. What DNAR clearly mentions, if the patient stops breathing or having a death or like having a cardiorespiratory arrest, you do not do chest compression. If you have a DNAR and your trauma patient, unfortunately, in front of you had a cardiac arrest, then you have to communicate with the team and mention like, this patient has a declared DNAR, so we have to stop and let the nature take its course. A very important thing in this situation here is communicate with the family if possible. Like, look, I know there's a DNAR and the patient is very terminally injured, and we believe the patient might not come around from this situation. So if the heart stops, aka if the patient is having a cardiorespiratory arrest, we are going to respect whatever decision is being made in agreement with the patient party and the healthcare professionals before. We are not going to start chest compression. So to answer both of your questions, it's most about communication, finding out the right information. And if you do not have the right information, you have to act as the best interest of the patient till you get the right information. Does it answer your question, Dr. Samira?
Yes, sir. Thank you so much.
Thank
Yes.
you, Dr. Sarja and Dr. Samir as well. I think our 1 hour window is about to be finished in a minute. Okay. Should we extend for a few further questions? Should we end our meeting today? Anyone has further question? If it is, we can log back in.
I have something to add on for
That's
a
fine.
minute.
So
I understand.
yeah.
So I understand that many of you are from Bangladesh. It's really nice to see many of you are joining. You're interested about emergency medicine. So I understand what we discussed today is about trauma management, the general way of communicating as per the ATLS way. and what happens in the rest of the world, what is not happening in Bangladesh. So it might feel overwhelming and to some extent some frustrating that we don't have neither the logistic nor the skills. So I would suggest you as a healthcare professional, you cannot change the whole world, but you can change yourself. So I would suggest from your side, you can gain the authentic knowledge. You can get the ATLS booklet. It is widely available on internet. If you search in the Google, you probably will get it. Or you can be with any of your friends. I would suggest go to the ATLS booklet, even if you cannot do ATLS course. You read, you gain the knowledge of how to manage a trauma patient, and you communicate with your other teammates so that you are on the same page. If you have to develop a skill like putting a chest drain tube in, how to manage an acute airway, how to do a CS spine assessment like a Canadian CS spine or some other ways. For you, the most important thing is gaining the knowledge and the experience so that if the situation changes, you can apply the knowledge, or within your limitation or your small bubble, you can use your knowledge. Yes, we all agree there is a logistic failure, there's a logistic need that cannot be addressed by one person. But what you can do, you can be skilled in your knowledge, in your skills, and up to dating with ATLS or similar trauma management. That is what we suggest to you. Thank you very much.
Thank you, Dr. Sarja. It was a very, I would say, is very concise and intense discussion. I think it's a very big topic. We didn't go into details and minute details of this, what we do, which is like an approach. How do we approach? It's like we give you an overview so that in Bangladesh, while we're working in Bangladesh, just to have an idea of what is expected in UK, what is done in UK, what is the gap in Bangladesh, and how can we try to fill the back. As Dr. Sarja said, we cannot do we may not be able to change the protocol or change the other people or context, but we can read ATLS book. We can read and enrich our knowledge and try to approach when the trauma patient arrives. Okay, at least we know what needs to be done. Okay, we can try what needs to be done, and then we address as we go. As I'm saying, this is not the last discussion. We will go forward. We'll probably have further sessions on discussing on trauma and other topics with Dr. Sarja and anyone who's working in UK. I'll try to bring everybody under the same umbrella. But Dr. Sarja, as I'm saying, I will be happy to have you in future sessions because I think you have extensive knowledge in terms of trauma, in terms of emergency medicine. So I think as a Bangladeshi community, we would expect you to come back again and give us more insight in future topics. And thank you so much for your time and everyone who is watching. And we have your emails and everything. If you have any question, you have think about it later. You just email me, or you have my WhatsApp number. So just message me. So if the next session, I can ask Dr. Sarja and to highlight any further topics we need to clarify. But we'll definitely need to go further sessions in the future. Thank you all. And Dr. Sarja, again, thanks for your time. And it was really lovely to have everyone in the today's discussion. If anyone
Thank
have
you very much, Dr. Farook.
any last minute question, if not, we have to say end our discussion today. And thanks to you all. See you the next session. See you in the next session. Thank you.
Thank you.